All right, so now we will talk about our electrocardiogram. Here in the States, we normally call this an EKG. In Europe, they tend to call it an ECG. ECG, EKG, it's the same thing. Just electrocardiogram. So ECKG. Okay. All right. Now, what these are basically going to be is basically where we're going to take we're going to stick some electrodes on their chest, and we're going to measure how the heart is beating. Now, what we're going to see here is we're going to see three types of waves. These are either going to be P, Q, R, S, or T. Okay. Now, importantly here, and what y'all need to realize or understand, is that the P wave is important because this is what's actually going to happen after the SA node sends out a signal. Okay. So when the SA node says, hey, contract. So SA node, remember, we have that depolarization, so it sends that signal out. This is what's actually going to cause atrial depolarization. This is essentially the electrical signal that is going to precede atrial contraction. Okay. So depolarization then is going to lead to contraction of that part. Okay. Now, the P wave is going to be this little tiny wave that's going to precede what we call the QRS complex. So we're going to see this little bump that is essentially the SA node sending out a signal to the atria to contract. Okay. Then we're going to see another peak, or a big peak. This is going to be called the QRS complex because it's basically a dip and then a peak and then another dip. Okay. This is what's going to happen when the ventricles are sending a signal. So this is basically your AV bundle sending out a signal through your bundle of His, and then finally to your bundle branches, and then up to your Purkinje fibers. Importantly here, this is happening while the atria are repolarizing. So whenever we send a signal, we're going to see that little peak of charge, right? But then we also tend to have to, or not tend to, we also have to bring those nerves back to their resting membrane potential, right? So we have to bring them back to their mean. So we have to repolarize. So we peak as our depolarization, and then we have to bring it back down. That is our repolarization. While the ventricles are depolarizing, this is when the atria are in the process of repolarizing, so bringing themselves back to mean. Then we're going to have another little peak, which is going to be associated with our ventricles repolarizing. Okay. Now, importantly here, we basically have what we're going to call two segments. These are basically like little gaps or like a little plateau. Okay. This is basically while we're waiting for electrical or cardiac action potentials. That's to say the contraction of the thing, okay, is what's going to be occurring in these little segments. Okay. So the segment between P and the QRS is going to be while the atria are contracting. So what is happening while the atria are contracting? Blood is getting pushed into where? So remember, we push blood down into the ventricles. So the atria contract and push blood down into the ventricles. And then the ventricles contract and push blood out of the heart, right? Atria contract to push blood down into the ventricles. Ventricles contract to push blood out of the heart, okay? So the ST segments, this second little pause in the electrical signal is when the ventricles are contracted. So this is your ECG or your EKG. So we have a small peak in the front, our P wave. This is the atria depolarizing, okay? So this starts our P waves when the SA node sends out a signal. The signal basically it's going to be seen as this little P wave. Then we have this little space, which is the atria contracting. Now, this space is normally quite small, okay? It's honestly looks a little larger even than normal right here, okay? So this space between the P and this QRS complex is usually fairly small, but this is where the atria are contracting. It makes sense that this gap is fairly small because the atria themselves are small, right? Now, once we get into the QRS phase, what we're going to see here is ventricular depolarization. So we send this big signal that says, bam, ventricles contract. So we have to send this big hard signal to tell them to basically contract big and hard. Okay, so just wham, contract. Push that blood out of the heart as hard as you possibly can. Okay, so as they receive their signal, we're going to have this little ST segment here, which is basically the space between the S wave and the T wave. This is where the ventricles are contracting. Okay. Now, in order for us to initiate that response at the apex of the heart for everything to repolarize, this is what's going to happen here at our T wave. So the T wave is the signal that is basically repolarizing, or not even a signal, it's basically the electrical wave that we see when the ventricles are repolarizing, basically coming back up to their resting membrane potential. So we peak, so we have to come back down. So that is going to be our repolarization phase, but T wave is actually where the ventricles are repolarizing. Okay, after the T, everything is nice and relaxed and we're waiting for the next signal. So from T between P, this is basically the gap in between kind of our heartbeats, okay? Everything is relaxed, so our atria are filling, everything is relaxed, okay? So in this phase, so in between T and P, muscles are relaxed, everything is filling, atria are filling with blood, the AV valves are open, so the ventricles are filling with blood. And then time for the next signal, we hit the P wave. So P wave is depolarization of what? P wave is depolarization of which part of the heart? Anybody? The atria. Okay, so you can kind of think about the contraction of the heart muscles as basically being top to bottom, top to bottom, top to bottom. Top contracts and then the bottom contracts. Top contracts and the bottom contracts. Okay, because we have to fill the bottom of it before we can squeeze all the blood out. Okay. So in this space, everything is relaxed, and then bam, SA node sends out a signal, causes the atria to contract. Atria contract, push the blood through their atrioventricular valves into the ventricles. That's happening in this PQ space, okay? Then we depolarize the ventricles starting at the apex of the heart. So we depolarize, and this is causing, this is going to lead to the actual muscle itself. So the ventricles contracting, which is going to push the blood out. They repolarize, the ventricles repolarize at our T. Now, the reason this is important, okay? We can't actually see the atrial repolarization. We can see the repolarization for our ventricles because it's not hidden by that PQRS, okay? So the QRS wave tends to hide our atrial repolarization. So here's a nice little diagram here. So we can see atrial polarization, atrial plateau, atrial repolarization, we can't see. Ventricles, depolarize, plateau, this is where the ventricles are contracting. And then T wave is essentially where they start to relax, okay? And wait on the next beat. Importantly here, say we mess with these intervals, okay? Say we take away these intervals from their ordinary kind of thing. Spaces between, say, the QRS and the T, this is what's going to happen under tach, okay? So like when someone says VTach, this basically means that the ventricles are experiencing this tachyarrhythmia. That's basically saying that there is not enough space in between these two things. That leads to kind of a rapid irregular heart rate, okay? Now, it's irregular because now things get out of order really, really quickly when this starts to happen. And this is because we're basically collapsing the phases where the ventricles should be able to depolarize before they get set for their next repolarization phase, okay? Now, if you mess with any of these things outside of normal, there are things that can lead to moving the P wave or having too big of a P wave or not having a P wave at all, or QRS not looking right. It could be too big, too small. They could be too close together. Any number of changes could occur that could drop us out of this perfect little P, QRS, T kind of thing, okay? Any sort of changes, we can manipulate these things. There are drugs that can manipulate them, but there are lots of problems that can occur to cause these little arrhythmias. That's not what we are necessarily worried about. And here, these are just some examples of what can cause this stuff. I'm not expecting y'all to be able to look at 10 different types of arrhythmias and be able to identify them and tell me what's happening on them. I basically just want you to be able to tell me what is supposed to be happening in a P, what is supposed to be happening in a QRS, and what is supposed to be happening in a T, okay? Understand that what a normal curve basically should look like, so that whenever y'all do take pathophysiology, that you can understand what happens when you break some of these things, okay? I'm not necessarily worried about y'all understanding what VTach is or anything like that, or atrial fibrillation or ventricular fibrillation, okay? Basically what all of these different things are going to do is anytime you have a portion of the heart that's receiving a signal to contract abnormally, it means that atria aren't getting completely emptied, ventricles aren't getting completely emptied, or they're not getting filled, which means you're being inefficient that way. Lots of things can occur to make, or if these signals are off, that's going to cause blood not to go where blood is supposed to go in the way it's supposed to go there. Okay, so we will lead to lots of problems down the road anytime these signals aren't exactly where they're supposed to be. Now, if anyone has ever seen a defibrillator, I think there may actually be one in this building over there by the door, or at least they were talking about installing some. These are basically a way of telling the heart to calm the F down and start beating normally again. Okay, so oftentimes when people start to have these kinds of crazy contractions and the signals aren't right and they're getting out of order, sometimes you can literally shock the heart. And so you try and send a little electrical signal to the SA node to try and bounce it back into its correct little sinus rhythm. Okay, so if someone is having just a bunch of rapid signals are going to that SA node, so the heart's trying to contract before it's had a chance to relax and all those kinds of things, you can send a little shock to it sometimes to reorient the peaks, and you can sometimes get the heart to start beating on its original rhythm again. That's what those defibrillators are trying to do. We'll talk about systole and dystole next time when we talk about blood pressure. All right, so we've talked a little bit about, okay. So here are some of the phases of the cardiac cycle. So once again, at the start of everything, we are completely relaxed. So as all the muscles are relaxed and we have our AV valves open, blood's gonna come in, okay? So as blood is coming in, you can think about this as like a cup with a hole in the bottom. You can still fill a cup that has a hole in the bottom as long as the flow into the cup is large enough, right? So we're gonna have a bunch of flow coming in, and some of that flow is gonna be allowed to drain into the ventricles, okay? Then atria contract. So we receive our P wave and the atria contract. When the atria contract, they're going to push their blood into the ventricles to try and fill the ventricles as much as they can, okay? So atria contract, fill the ventricles. Then our next stage is going to be a contraction of the ventricles. Here it's calling it isovolume, okay? So the same volume. So we're going to contract and we're going to squeeze out the same volume out of the left side as we do the right side. If this isn't done correctly, so we get different volumes, we can lead to swelling in particular places because fluid gets stuck, okay? So that's what an edema is basically fluid buildup in places or blood buildup in places oftentimes due to incomplete emptying, or the volume is not isometric, okay? So it's not the same, okay? So ventricles squeeze, contract, and try and squeeze out the same amount of blood. So then they eject that blood out their semilunar valves. So the right side pushes it into the pulmonary trunk, so out through the pulmonary semilunar valve. The left side pushes it out the aorta, okay? Then they relax and once again open themselves back up to the same amount of volume. So once again, it is important that ejected blood volumes are the same, okay? The left side is only bigger, not to make the volume smaller. The left side is bigger just because it has to pump harder, okay? Now, you might consider think about all this stuff in terms of like cardiac output, okay? That's basically say how much blood can we move out over any given period of time, okay? A good example here would be if your heart is beating, where is it? 75 beats a minute, okay? So heart rate, so 75 beats per minute times the stroke volume, okay? So this is basically like how much blood are we ejecting in like how much blood are we ejecting? This is gonna be our equal to cardiac output. So 7 beats a minute and we're moving 70 milliliters per beat. This means we're going to move through 5.25 liters in a minute. 5 liters should sound familiar. What is 5 liters equal to? How about the average volume of blood in an adult? So with a heart rate of 75 beats a minute, this means you will cycle through all of your blood in a minute. That's how fast this stuff is moving through. Now, importantly here, if you are healthy and you exercise, you can actually increase how much blood you can move through in a single beat, which means if we still want to maintain this rate, so if this goes up, but this stays the same, what can go down? Your heart rate. So this is like what I was talking about before, where people that are athletes and things like that, this number tends to get low, but that's because this number tends to get fairly high. So they tend to be quite efficient. So they can move more blood in a single beat. But importantly here, we have to make sure that the cardiac output is meeting the tissue needs. So say you need more oxygen to your tissues, what do you have to do? If you need more oxygen to your tissues, that means we have to increase cardiac output, right? So if we need to increase cardiac output, that means we're probably not going to change the volume of blood very much because that's going to be pretty static. So what do? We increase the rate we move it, right? So how many times we're beating. People that are smaller tend to have smaller stroke volumes. That makes sense, right? Like you had a sheep heart in front of you. There was variance in those sheep hearts, right? In size, theirs was really big. Y'all's were about the same size. Y'all's are probably roughly equal to humans, which means you're probably looking at a sheep that weighed 100 and something pounds, 150 pounds or something like that. Y'all's was big. So y'all probably had a larger sheep, has to move more blood, right? That makes sense. The bigger you are, the more blood is necessary to go to all of your tissues. The smaller you are, the same thing is going to be true. This is why oftentimes, like if you work in the medical field, if you say have a patient that is 75 years old, is not very active, and they're a tiny little lady, so she's like 4'9" and maybe 85, 90 pounds, her heart rate is probably pretty low. Usually just, you don't need that much. It doesn't have to work very hard, so it doesn't have to beat very fast to move all the blood needed through the system. So their heart rates will tend to be lower. Whereas if you find someone that's 6'8" and 365, their heart rate is either going to have to be faster, or they're going to be moving more blood per beat. Okay, so we are going to see a lot of variance in here. Yes, younger kids tend to have a little bit faster heart rates, yes. But their hearts are smaller, so in order to move the volume around. That tends, especially like that's for younger kids, like once they get into like the 8 and 9 year old range, it tends to even out pretty much. Typically, I would think, at least it's supposed to. I haven't measured that many heart rates. I've just read it though. So, oh, teenagers. Okay, yeah. Lots of variance here too. Also, like there are some people that tend to have white coat syndrome and stuff like that too. So simply being in a doctor's office can make their heart beat faster and all kinds of fun stuff. Or like, say you're someone like me, like I used to have all of that stuff checked at like our on-campus clinic when I was at UTA, but that was like a better part of a 3/4 of a mile walk from my office to there. So just walking over there, I'd start to schwitz a little bit because it's like 104 or something like that. So like my heart rate would go up just from walking that distance. And I don't know if y'all have ever seen me walk. I walk really fast. If I'm walking somewhere, it's because I'm trying to get somewhere, not trying to dawdle. So I tend to walk faster than everybody. So I would get there. So just walking there, my heart rate would be elevated, my blood pressure would elevate and stuff like that. So that's also something to kind of keep in mind in those kinds of things too. However, athletes, especially endurance athletes, will tend to have thicker heart walls and thus stronger hearts. So they tend to be very efficient with making sure that things get emptied correctly and stuff like that. So they tend to move more volume in a beat, thus their heart rates can be slower. So there are some things in here. This is really less anatomy. It's just all more physiology stuff. So yeah, that's just all physiology stuff. All right. So if you have any questions about heart anatomy things or really any of the physiology stuff, just let me know. But we are pretty much done for today. So if y'all want to continue studying all the parts and pieces, you can. If you want to go back there and play with your cut up sheep hearts, you can do that as well.